Hello students, today I will discuss about the management of asthma, that is the stepwise approach towards the management of asthma. In step 1, we give patient short-acting beta agonist, that is Ventolin, as required. But if patient symptoms they are not controlled by SABA, then in step 2 we add low-dose inhaled corticosteroid. In step 3, we add SABA plus inhaled corticosteroid low dose. Along with that, we add leukotriene receptor antagonist. So you have to memorize this, that in step 3, we need to add leukotriene receptor antagonist. Leukotriene receptor antagonist is added in step 3. While step 4 is a sandwich. Basically, leukotriene receptor antagonist is in the middle of the sandwich, and on one side there is SABA and on other side there is LABA. So between SABA and LABA, there is leukotriene receptor antagonist. That is step 4 is sandwich. Then in 5 and 6, along with SABA and leukotriene receptor antagonist, we add MART. MART stands for maintenance and relieving therapy. This maintenance and relieving therapy, it comprises of an inhaler which has combination of long-acting beta agonist and inhaled corticosteroid. So this MART is added in step 5 and step 6. In MART of step 5, LABA is added with low dose inhaled corticosteroid in single inhaler, while in MART of step 6, LABA is added with the medium dose inhaled corticosteroid. So this is the difference between the MART of step 5 and step 6. So again, I will repeat, in step 3, we add leukotriene receptor antagonist. Step 4 is sandwich, that is a sandwich of leukotriene receptor antagonist between SABA and LABA. Then 5 and 6, we add in SABA plus minus leukotriene receptor antagonist MART therapy. And in 5, this MART therapy, it comprises of LABA and low dose inhaled steroid, while in 6, it is LABA plus medium dose steroid. In step 7, what we do is that we omit MART therapy. Along with SABA plus minus leukotriene receptor antagonist, we add separate LABA and separate high-dose inhaled corticosteroids. And along with it, we can also add oral steroids or long-acting beta agonist in the tablet form or theophylline. So this is the stepwise approach of asthma. After stepwise approach of asthma, we come to COPD. First of all, we'll discuss about the management of stable COPD. Now, there are two types of COPD. One COPD is with the element of reversibility. That is, if after bronchodilator therapy, FEV1 is increased to 400 cc or there is 20% increase, and in this COPD, we also get eosinophilia. It means that it has got element of reversibility. So in that COPD, if patient is using SABA before, but it is not being controlled by SABA, we replace this SABA with SAMA and we add LABA plus inhaled corticosteroid. Yeah, it means that in step 2, we add two medicines together. That is LABA plus inhaled corticosteroid. And if patient is not controlled by step 2, in step 3, we add LAMA also with this. So in step 3, we have got LABA plus LAMA plus inhaled corticosteroid. But inhaled corticosteroid is only given in that patient of COPD which has got element of reversibility or eosinophilia. While in that case of COPD where there is no reversibility and patient is using SABA and is not being relieved, we replace it with SAMA. Or if he's using SAMA and is not being relieved, then we replace it with SABA. And in this COPD with no element of reversibility, in step 2, we add LABA plus LAMA. Plus there is another drug which is called roflumilast, which is a phosphodiesterase inhibitor, and we consider this in those patients of COPD who has got FEV1 of less than 50% and who has got 2 exacerbations of COPD in last 12 months. Here I want to say that what are the common organisms which cause acute exacerbation of COPD. These are Haemophilus influenza, Moraxella catarrhalis, and Streptococcus pneumoniae. Then after that, what are the factors which cause long-term survival in COPD? This is number one, smoking cessation, then volume reduction surgery, and then LTOT, long-term oxygen therapy. Now, there are certain indications for long-term oxygen therapy, and these are that if the patient's oxygen partial pressure is less than 7.3 kilopascal, this alone indication is sufficient to start long-term oxygen therapy in this patient. But if the partial pressure of oxygen is between 7.3 to 8 kilopascals, then we need one of these four factors. Either patient should have pulmonary hypertension, or he should have polycythemia, or he should have pedal edema. So, long-term oxygen therapy is given, that is 15 hours per 24 hours. As far as acute exacerbation of COPD attack is concerned, we give back-to-back nebulization with SABA, and in step 2 we can give oral steroid if patient is stable enough in a dose of 40 to 50 milligram OD, or we can IV steroids. Then in step 3 we can add antimuscarinic, short-acting antimuscarinic agents. If still patient is not being improved, we can add theophylline, IV theophylline, and as a last resort we can give patient non-invasive positive pressure ventilation. Here we keep the settings like we give inspiratory pressure of 10 to 14 centimeter of water, and expiratory pressure of 4 centimeter of water, and inspiration to expiration ratio is 1:3, while the respiratory rate is kept as at 12 per minute. Thank you very much.